ده سامعيني حدا فيكم يقول لي السلام عليكم؟
وعليكم السلام.
دكتور.
السلام هنا دكتور.
اوكي ماشي. يعني راح نشوف ان شاء الله نحكي اليوم عن الرينال تيومرز. هلا before we go into talking about renal tumors, I think I would just quickly go through some slides in the عن محاضرة اليوروليثياسيس اللي حكيناها ذاك اليوم. بس just a quick reminder لإلكم شوي missing slides تكون شوي الأمور أوضح للمعطيات هاي. لا okay, I would not go through these things. I would just go يعني أنا متهيألي ما كانش كتير واضحة CT without contrast. هلا if you look at this X-ray or this PowerPoint or this slide في عندكم أكثر من CT. إذا بنطلع على ال right hand side of the slide, which is your left hand side, طلعوا على على right kidney, you can see a radio picture at the tip of the arrow, which is the stone. إذا بنطلع على جنبه left side على left side of the slide نشوف arrows موجهات على الهيدروفروسيس. إذا نطلع على آخر السلايد نص التحتاني بنشوف إنه there is a radio picture in the lower ureter and these are stones. Other X-rays or other CT scans you can see radio picture those left hand side right hand side. المريض unluckily عنده kidney and ureteric stone on the left side and kidney stone on the right side. هاي بتعرفوها اللي الكونتراست which is white. ترجعوا تشوفوا كيف شكل الكدني على الهون it's almost gray غامق. هون gray فاتح في contrast. هلا as we said complications in obstruction by calculus will lead to hydrophorosis atrophy and progressive loss of renal parenchyma and sometimes infection either calculus perinephritis or calculus pyelohydrophorosis. Treatment, as we said in the other day, اللي هي either treating the stone itself or you treat the complication of the stone. هلا بس في عندي هون one slide I want to show which is urgent procedure treatment when we admit the patient to the hospital and the patient needs a procedure to be treated for him or her. First of all, when the patient is unremitting, yani we give analgesia and the patient is still complaining of pain, so or we sent him home and he or she came back with another attack of unrelieving pain even without analgesia, so this is indication for admission or even procedure. Significant obstruction, if the patient is having significant obstruction, counting the degree and the duration of the obstruction. If the patient is having deteriorating renal function, if the patient is developing oliguria anuria in bladder obstruction or obstruction in the circulatory system with transvaal kidney, and the last one is if the patient is febrile, which means there is associated infection. We discussed this when we discussed the patient, whether the patient's first stone or second stone, and the last thing, vesicular calculi or the bladder calculi, which means always we do an X-ray, we look at the pelvis, and we can look at this X-ray, we can see multiple radiographies in the bladder. Again, male more than female. Primary usually calcium oxalate, most common in the United States and in United States and Canada. Primary uric acid stone urate prevalent more in Europe. Secondary stones because of retention, BPH, or even any pathology in the bladder. And again, the presentation is lower tract symptoms. وحكينا شو هم lower tract symptoms, adaptive or obstructive incontinence, upper tract symptoms بينهم hematuria. I think in the round we discussed most of these symptoms. other parallel calculi, and by this I would just don't want to say anything about the urethraces. Before I go into our renal system, is there any question till now, ya shabab, you want to ask, or everything is okay? I think إنه
دكتور
clear.
ممكن بس شوي دكتور.
اوكي، انا بحكي بسرعه بس لاني بتهيالي اني بديش اضيع لكم وقتكم بموضوع انه ستيل ليت والوقت تاخر شوي صغيره، وبموضوع انه احنا بدنا ندخل بالمحاضره تبعت الرينال ستون عشان تقول شو الدكتور اسامه يعني ضيعنا. بس لا اوكي، هلا we'll talk about slowly and اللي حكيناه بالمحاضره الرينال ستونز وكان continuation للراوندز اللي داوموا معي راوند او حضرنا مع الراوندز يقولوا الاسبوع اللي فات الاسبوع هذا انه what's there in the urology presentation and urology history. What does it mean renal failure to collect and irritative voiding symptoms. بس هلا slowly we will ان شاء الله be more slower. بعدين thank you for mentioning this, but be sure that whenever any person talks very fastly, either he or she is fluent in English or he is not fluent in English at all. فبده يخلص من انجليزي بسرعه مشان ما حدش يلقط غلطاته، او انه بده فيش ديسكشن من اللي حواليه او فيش انتراكشن حواليه، فمعناته بده يخلص من الموضوع كله. فانا اسف جدا. Okay, we just go to the now the main part of our our tonight or our this night lecture, which is about the renal cell cancers, RCC. Mostly we're talking about the renal cell tumors. To start with, most of the renal cell tumors are malignant until proven otherwise. So we will discuss firstly the renal cell carcinomas or even the malignant tumors of the kidney. Just a quick reminder for you, we know that it represents around 22% of all cancers, so it's not really a very common cancer. Other cancers are more common. 98% are adenocarcinoma, and they arise from the proximal tubules of the parenchyma. وإذا بتتذكروا أو بعرفش إذا كنتوا أنتوا لا أو غيره, we know that we have three types of epithelial cells in the body. We have the squamous, which is mostly found in the ectoderm, skin and its derivatives. All the ectoderm derivatives are squamous epithelium, while the mesoderm and endoderms are mostly either columnar or cuboidal. عادة بنقول بسأل أنا بكون برا عشان أذكركم مين الكولومنر كويد اللي فيها سي أكثر needs for absorption. بنقول الكولومنر, so we find more columnar in the GI tract, so we find more cuboid in the GI tract, in the genitourinary tract, and mostly in the kidneys in the renal parenchyma, because we know that the alignment of the urinary tract, which is the epithelium, is a special type of epithelium called transitional cell epithelium, which is found in the kidneys, in the pelvic system, in the pelvis, in the ureters, in the urine bladder, and the whole urethral length, except the last 2 centimeters lined by squamous epithelium when migrating from outside to the inside. 15% of these tumors are Wilms tumors, especially in pediatric age group, or transitional cell carcinoma from the transitional epithelium, or sarcomas from the capsule fibroma or the muscle that's found in the kidney or around the kidney. It's the most lethal urological cancer. Other cancers are really less dangerous, and it's the 5th most renal lethal cancer all over the world. It increases in all ages, on all groups, till the mid-80s. Increase between after the age of 40, a peak age between 60 and 70 years, and it decreases after the age of 75, and usually males are affected more than females. I'm going slowly, is that okay? Again, adenocarcinoma, renal cell carcinoma, it's an adenocarcinoma of the renal cortex from the proximal tubules. 7% are multifocal and around 2% are bilateral. Mainly it's solid but can be cystic and contain calcifications. So it's mostly a solid tumor. Usually the spread is mainly through the renal vein. Around half of the patients they go through the spread through the renal vein, and whenever they go into the hematogenous stream, the most affected part is the lungs, followed by the bone and the liver and the brain. And sometimes we have lymphatic spread, usually to the para-aortic lymph nodes, because we know that they originate the para-aortic in the kidney close by to the para-aortic lymph nodes, and in between the aorta and the cave, some inter-aortocaval or retrocaval lymph nodes. We have many histological types for adenocarcinoma of the or renal cell carcinoma. The most common is the clear cell. Usually, as we said, it's from the proximal tubules. It's very vascular, and those patients they have increased incidence of von Hippel-Lindau gene on chromosome 3. Chromosome 3 of that way. So VHL is von Hippel-Lindau. It's a disease that is more, with those patients, they are more prone for renal cell carcinomas, mostly clear cell. The other types, 15% around papillary, usually 40% are bilateral, and they have no abnormal, the gene is found in chromosome 7 or 17. Less, around 5% chromophobes. Usually it arises from the cortical part of the collecting ducts, and it is the least aggressive type of the tumor, surgical type. The other rare tumors, collecting ducts and medullary, they represent less than 1%, and usually they have poor prognosis and they are very rare, fortunately. The collecting and the medullary types of the renal cell carcinoma. This is a slide. We can see most of the cells look very whitish, like a clear fatty cell. That's why we call it clear cell carcinoma. Whenever we grade these tumors, we use the Farman system. That is composed of 4 grades, depending on the nuclear size, the contour, and nuclei. And this is mostly a histological diagnosis or histological grading. Grade 1 is the best, and grade 4 is the worst. And we can see that whenever the grade 1, the 5-year survival is around 90% or 85%, while grade 4 goes to 1/4 of the patients, they hardly live 5 years of age. So it means it's very aggressive. The Tnm classification depends mainly T tumor size, N lymph nodes, M metastasis. And when it comes to the T, we know that the T1, T2, T3, T4 mostly depends on the size. Any size less than 7 centimeter, it is T1, more than 7 centimeter is T2. T3 and T4 is mainly, in addition to the size, there is a local spread to the Girota or even to the hilum, grade 3, and Girota, covering of the caps of the renal of the kidney, Girota's fascia. This is the T4. Now, when it comes to the lymph nodes, if there's no lymph nodes, it's mainly N0. If positive lymph nodes, it's N1. The same thing. M0 node, distant mets. M1 distant mets. As we said, most of them they go into the lungs and then bone, liver, and brain. If you want to combine the staging with the Farman grading with the prognostic group and get a prognostic grouping, we will say stage 1, mostly this is T1 tumors, stage 2 T tumors, and on stage 3, stage 4, there's local lymph nodes, and stage 4, any metastatic region. So this is what we call the Tnm classification. We have many etiological factors behind renal cell carcinomas. Some of them they are environmental, and nowadays genetics is going into most of the renal tumors. وإن شاء الله فيكم أنتم تكونوا فاهمين بالجينيتكس أكثر منا، لأنه أنتم بتهيألي درستوا أكثر جينيتكس أكثر منا، إحنا حفظناهم حفظ، أنتم بجوز درستوا جينيتكس، وإذا ما درستوش إن شاء الله بيكون منكم أجيال لستدي جينيتكس أحسن منا. A lot of the environmental factors such as tobacco smoking. tobacco يعني يا شباب الدخان والأرجيلة، مش بس السجاير. الارسنيك، الاسبستوس، الكادميوم، الاورجانيك اللي بيشتغلوا بالدهان والمصانع. الobesity, hypertension, and an old drug called benzene that's used for migraine. We don't use anymore. Now, when it comes to the genetics, the most important one is the von Hippel-Lindau disease or gene. We have the Bert-Hogg-Dube gene. We have the hereditary biliary cell carcinoma, and hereditary leiomyomatosis and renal cell carcinoma syndrome. The most common is the von Hippel-Lindau disease or gene, first described by an ophthalmologist. It is an autosomal inherited disease. Usually, this chromosome is located. This gene is located in chromosome 3, piece 25. The manifestations of von Hippel-Lindau disease is hemangioma of the retina and the central nervous system, renal cyst, increased risk of renal cyst and renal cell carcinomas, pheochromocytomas, pancreatic cyst, endolymphatic sac, and epididymal papillary cyst adenomas. So these all are manifestations in von Hippel-Lindau disease, with many manifestations you can see, but the most important thing are the eye and the renal manifestations. Clinical features as you look, the retinal lesions occur first. The mean onset around 25 years of age, and most of these patients, if they have CNS hemangiomas, they occur later in life, around 30 years of age. And then renal cell tumors, and they are young, 37, because we know that the peak incidence between 40 and 60 years of age. So if they carry the von Hippel-Lindau gene, they are more prone for tumors and early development tumors, but fortunately they are clear cell. The diagnosis, usually patients they have a positive family history. We see hemangioblastomas on the retina or CNS, and we have extraneural lesions. And any one of the clinical features اللي حكيناهم قبل شوي طبعا in the kidney or in the pancreas as a from von Hippel-Lindau disease. Presentation of renal cell carcinoma. Half of these patients they come incidentally. We do a CT scan for the abdomen for many reasons, abdominal pain or even GI, and we find a renal tumor, and this is what we mean by incidentally. So they do not present to the urology or to the physician because of renal pathologies. Mostly they present because of other non-genitourinary or non-renal presentations. We do a CT scan or ultrasound will show us a tumor or a mass in the kidney, and this is what we mean by incidental presentation. Less than 20% or 25%, a quarter of the patients, they present with a classical triad, which is hematuria, pain, and mass. With, as you look at the slide or see the slides, different incidence rates. Hematuria is the most common of these. Hematuria, loin pain, and mass. Quarter of the patients they present with the classical triad, and 1/4 of the patients they present with, unfortunately, with metastatic lesions to the body, either locally or even distant nuts. Just to mention, this very rarely they present testicular pain or even lower lip edema. With testicular pain يا شباب تتذكروا إنه testicular arteries and veins on the left side, they come from the left renal artery and vein. while on the right side they immediately go into the aorta or vena cava close by to the renal artery and renal vein. Some patients present paraneoplastic syndrome. والبارانيوبلاستيك syndrome يا شباب أكيد سمعتوا عنه أو قرأتوا عنه. It has many elements. One of them is the hematological, where the patient is having either anemia or polycythemia vera. They may have systematic manifestations, raised erythrocyte sedimentation rate, Stauffer syndrome, which is the liver dysfunction, which means there's increased risk of bleeding because of high PT, or even jaundice, or even jaundice, which is the non-obstructive jaundice. Amyloidosis, which means deposition of amyloid bodies on the body, in the kidney, or even the heart. Around 10% of these patients, they have hypercalcemia. 10% they have erythrocytosis, which is polycythemia, and they have high incidence of clotting and clot formations all over the body, especially in the heart or even the lung, leading to either MI or pulmonary embolism. One third of these persons, they have hypertension, mostly, and sometimes they have hypoglycemia and fever, and all these are systematic manifestations of paraneoplastic syndrome. We were going to go to investigate these patients. We divide the investigation into, as we said, laboratory investigations and radiological. With the laboratory investigations, we ask for CBC, and the CBC, the aim is not just to make it as a baseline, look for either anemia or polycythemia, or we have a platelet abnormality. ESR, erythrocyte sedimentation rate, which means which will be elevated whenever there's tumor in the kidney. Kidney function test, looking for renal impairment or even abnormality in the electrolyte, sodium and potassium. Liver function test, as we said, Stauffer syndrome, and evaluating the liver enzymes to rule out any liver dysfunction or any liver mets. And the last one, which is the most important one, is urine analysis, urine culture. With urine analysis, the main scope is looking for hematuria. Culture is to rule out infection because it can be one of the differential diagnoses of a renal tumor, either because of perinephritis or granulomatous perinephritis or localized perinephritis, which can look like a tumor in some patients. If you go to the radiology investigation, which is the most important thing, you have to see the tumor yourself, either with ultrasound or CT scan. But the CT scan should be with contrast. IV and oral mesothelial urethritis should be without contrast. It should be with contrast, and if it was a tumor, it will be enhancing. So the tumor or the mass will take the contrast. This would be enhancing. يعني يبين بياضه مش ضله انه رصاصي او غامق. And if you look at the CT الصورة اللي معاكم, you can see there is a huge tumor on the right side, and it is mainly من حوالي أبيض, معناته it's enhancing. Sometimes we ask for MRI or MRU in very specific cases or limited cases. Still, it's expensive, and there is no much experience in that. We may go and ask for angiogram if the patient is having huge tumors and we want to devascularize the tumor or know the anatomy before we doing the surgery. Devascularize معناته we inject the material that will go and lead to thrombosis of the renal artery, the main supplying vessel to the kidney, the whole kidney or the tumor, and ischemia would happen for the sake of tumor control before surgery or even symptomatic control. Sometimes, if we are suspicious that this is not renal carcinoma, we go for biopsies. The classical teaching زمان كان يقولوا don't go for biopsy. كانوا زمان ياخدوا core biopsy, which means that the needle is big, but there's increased incidence of mets. But nowadays it's small bore needles, so risk of metastasis is very minimal. So sometimes we go for tumors for biopsy, especially I'm dealing with bilateral tumors and I want to plan my management, because we know till now, treatment is getting rid of the tumor, which is the nephrectomy. And the gold standard, the old classical teaching is radical nephrectomy, which means I have to take out the kidney, the whole kidney, within its gyrata fascia, with the the suprarenal gland, the adrenal gland, but nowadays partial nephrectomy where I can take the tumor with safe margins حواليها, especially in the lower pole. It was amenable without taking the gyrota or even the suprarenal gland, and some publications now even they claim it's almost equivocal to the radical nephrectomy. Now the approach, whether this is open surgery or even laparoscopic or even robot surgery, is almost equivocal. Unfortunately لسه ببلادنا ما في عنا بالأردن روبوت. حتى اللي اتدربوا على الروبوت they lost their skills because we don't have robot. بس الحمد لله في عنا روبوت بالسعودية، وفي بلبنان وفي بالإمارات، وفي إن شاء الله حدا فيكم بروح على أمريكا ولا على أوروبا and he or she will master robot. ليس مش بعيد على ربنا. one of our colleagues اللي كان student عندنا بالجامعة، عندكم زميلكم خريج 2009 I think. Now he is doing just only robot radical prostatectomy. كل حياته بس بعرفش يسوي غير يشتغل روبوت radical prostatectomy in Germany. He's a consultant and he's he will be a figure إن شاء الله in the coming few years all over the world. So ليس على الله بعيد. بتمنى انكم تكونوا كلياتكم تصيروا احسن منا، احسن مني ومنكم at this time being. So nephrectomy is the gold standard test. Sometimes we go for partial nephrectomy if the patient is having a single functioning kidney or a multifocal tumor, so we go for a partial nephrectomy, trying to preserve as much kidney as we can for the healthiness of that person. T2 we go for radical nephrectomies, and sometimes we go for just simple palliative open nephrectomy for tumors that they are high stage T3 or even above, because we need to have local control. In addition to other treatment options, chemo or radio. And this is what we mean by nephrectomy. We take out the whole kidney, included, cannot see the kidney, included in the sample. إذا بتطلعوا هذا مريض أنا عملت له بهالزمانات nephrectomy. It was a huge tumor. يعني this is the therapy pencil، القلم اللي أو يعني pencil اللي بنستخدمه مشان نعمل diathermy للبلود vessels أو للsmall vessels. This tumor was around 70 centimeter. It's all included within the gyrota. اليوريتر تحت مبين. بالراديكال معناته we take as much as we can of the ureter, upper ureter. We don't go to the lower ureter لأنه mostly this is renal cell carcinoma. And إذا بتطلعوا على الصورة قبالكم you can see that the upper pole من تحت شوي مبين أبيض، بس اللي جنبها مبين pinkish يعني which is healthy tissue، بس الأبيض it's a huge tumor almost occupying the upper pole. That's why at that time we decided to go for radical nephrectomy لأنه partial nephrectomy صعبة علينا من ناحية إنه it may this is an upper pole tumor. It may include the suprarenal gland, and it was at that time I remember later on we discovered it was multifocal. So this is a radical nephrectomy. Sometimes we don't go for surgery. The options that we have active monitoring. If the patients have active monitoring, which means just follow up and you just intervene whenever the patient is ready for surgery. And we use active monitoring in very selective cases if the patient is having T1A tumor less than 4 centimeter, which is rarely can spread, or the patient is not fit for surgery, or he or she is an elderly patient having or suffering some other pathologies, heart or pulmonary, and the patient would not die from his renal or renal cancer. The other is the corrective treatment, where we go for nephrectomy, so one can radical or simple, just try to improve the response to medications. Medications mainly, most the indication that we use is the angiogenesis inhibitor drugs or immunotherapy, because we know that most of the chemotherapy and radiotherapy usually have no role in these tumors. This is regarding renal cell carcinomas. The other benign tumors mostly are either oncocytoma or angiomyolipoma. الانجيوميلايبوما which is oncocytoma نرجع لها it is a benign epithelial neoplasm around 10%, less than 10% of renal masses. Usually it's because of histological mitochondria rich eosinophilic cytoplasm, and it sometimes can be confused with chromoform RCC. So even with a biopsy cannot be helpful. So we go for nephrectomy, and after nephrectomy, the histopathology comes back as oncocytoma. So we just get relaxed, and we know that this is therapeutic because it's benign. Otherwise, the cancer pathology units carcinoma, we have to follow these patients. While with oncocytoma, usually it's very benign, and it arises from the collecting system. It has a box wheel pattern، يعني زي الإطار العجل السيارة، عجل مرسيدس جداد أو حتى أي سيارة، بياخد شكلها زي شكل السبوك ويل. بدناش نقول cross, more than cross, 4 or 5 or 6 wheels inside the kidney. You can see it on the CT scan very clearly, and this is very difficult for oncocytoma. The other part is the angiom, or the other part, type of renal masses is angiomyolipoma. ومن اسمه في عندي angiom vessels, myome من muscles, ولipoma من fat. It is a benign mesenchymal tumor. It has the both tissue fat, smooth muscles, and abnormal thick blood vessels. Usually females are affected more than males. 1/5 of these patients, they have tuberous sclerosis, which is an autosomal dominant neurological disease, and those patients, they have increased risk of angiomyolipomas. Usually it's very vascular because of angio and contains fat. إذا تطلعوا على السلايد there is a lot of fatty cells البيضاء، وبيناتهم الزهري اللي هي الانجيو vessels as you see in the slide. Presentation, like it's like any renal tumor, mostly they present incidentally. 1/4 of these patients, they present with bleeding in the kidney or in the tumor, especially if the tumor is, the size of the tumor is more than 4 centimeters. So this is a mandated treatment. The treatment is nephrectomy, and more complications to happen in the renal angiomyolipoma. We have a very rare condition recently diagnosed. It's been of course called mutant adenoma, and usually it's histopathological diagnosis, and it just comes after we do the nephrectomy. By this, I ended my talk. The floor is open for questions. It did not take much time, but لما نداوم مع بعض سواء اونلاين ولا وجاهيا هنكتشف انه يا شباب whenever we talk about the upper tract symptoms, we talk about pain, and whenever we analyze the pain, You have to know that there is the renal pain, uterine colic, and renal colic. Renal pain is حكينا one of the causes is a dull, it's a dull, a continuous pain, or ache معناته pain, the dull, a continuous gradual pain in the loin caused by multiple many diseases. حكينا one of the groups of disease is specifying lesion of the kidney, many specifying lesion of the kidney اللي هي حكينا محاضرة اليوم الرينال سيل كارسينومز اللي هو بسموه malignant or benign tumors. أو حكينا hydronephrotic causes, which is a pathology that leads to hydronephrosis, which is accumulation fluid in the pelvic renal system leading to distension of the renal capsule. والمثال تبعها الستونز اللي حكينا عنها المرة اللي فاتت كملنا شوي صغيرة عنها اليوم. So the bottom line يا شباب, please understand exactly what does the renal pain and where is the kidney pain is felt in the loin and where is the loin and the characters of the renal pain. By this I finished. If you have any comments or questions, the floor is open. I hope I did not take much of your time. Clear slides, and it's just not a busy slides. Simple and easy to memorize and know
يعطيك
for
العافية.
you to practice. الله يعافيك يا شباب. تفضلي دكتورة.
يعطيك العافية دكتور.
الله يعافيك والله يسلمك.
عندي سؤال هلا، ليه
يعطيك العافية
بالأونكوسايتوما
دكتور.
الله يعافيك الله يسلمك.
ليه بالأونكوسايتوما بيكون التريتمنت نفركتومي؟ يعني مش هي بناين، ولا ما بقدر أعمل دايجنوسيس إلا بعد ما أعمل نفركتومي؟
ما حكينا انه اذا بنرجع على موضوع الانكوسايتوما، اذا بنطلع على هون على البيوبسي is not diagnostic because it looks like chromophobe RCC renal cell carcinomas. فالمشكله الباثولوجي الباثولوجيست اللي حدا فيكم باثولوجيست ان شاء الله بالفيوتشر ما بيقدر يقول لي وحياة الله this is oncocytoma. CT I may see the spoke wheel appearance, but الcomposition تبعها والcystic والcystic composition والsolid composition كانت خربة. والage almost like the same age 40 60. فمعناته this is unfortunately انه يعني patients they come and they push you towards surgery. I want to get rid of the cancer. I want to get rid of the cancer. بس بعدين تطلع عنها benign بتقول الحمد لله رب العالمين. So mostly it's a histological diagnosis, but sometimes we get lucky and we can it's in our differential diagnosis and we can say that this is oncocytoma. We assess the patient, he or she, the age, the look on the CT, the biopsy, the current surrounding lymph nodes, other paraneoplastic disorders, and the risk factors زي ما حكينا عندي genetics of one hip Lindau or other syndromes, how the patient is smoker or كل الانفيرمنت causes حكينا عنه قبل شوي. ساعتها ممكن اقول انه بديش اقول اروح على فور nephrectomy او just radical nephrectomy simple nephrectomy or just keep it there and observe. بس يعني عادة لأن الرينال cancers are lethal, so منصبرش أو منسكتش على كانسر أو على تيومر موجود بالجسم جوا أو الكدني جوا الجسم. زي أنا مركز بقول زي اللي بيروح بيكون حرامي بيروح على شرطي بقولوا أنا سرقت تحبسنيش، وأنا يعني متهيألي صعب إنه يجيني مريض ما عملوش أناليسيس as a start وبعدين يجيني واحد عنده لين تيومر أسكت عليه.
أوكي تمام، يعطيك العافية دكتور.
الله يعافيك. يعني أنا بديش أطول عليكم لأنه حتى إجانا اليوم تعميم إنه بدناش نعطي محاضرات أو نكون أي شيء بعد الدوام الرسمي، الطلاب صار يشكوا. أنا والله أنا امبارح لما زميلكم حكى لي قلت له يا 4 يا 8 على أساس إنه أكون فاضي هذاك الوقت، فيعني كانت شوي بس خياره كان الساعة 8، فأنا بعتذر مرة ثانية عن التأخير أو عن الليت talk بس يعني الحمد لله رب العالمين. And I don't think this is harmful because the most important thing يا شباب is commitment. Please بالله عليكم يا شباب تعني boys and girls, show commitment to your future, your future life. Your future life is a doctor, is a physician, treating yourselves and your beloved people and your patients. Commitment is part of your life. صدقوني يا إخوان كل اللي تأذوا من الكوفيد كانسر الكوفيد 19 الله يرحمهم ويعني ويعوض عليهم بالخير سواء كانوا physician أو non physicians. Part of their illness is ignorance and negligence. Ignorance and negligence, which is not commitment. You should be committed يا شباب to your physical or medical activity and medical life. I hope this message is clear to all of you. سواء you got infected or not, بس أنا متأكد إن في ناس كتير got infected and they got a very bad result. Have a nice night all of you. Good luck. حاولت أحكي شوي نلتقي على خير إن شاء الله next week إن شاء الله رب العالمين. تصبحوا على خير. أشوفكم على خير إن شاء الله.
يعطيك العافية دكتور.
الله يعافيك.
يعطيك العافية.
الله يعافيك.
عافية دكتور.
شكرا.